This is my return demo video on administering heparin to a patient who's been diagnosed with a PE. I'm using the protocol listed in Lab 3. It's a pretty standard protocol for a patient diagnosed with a PE, 80 unit per kilogram bolus, followed by an 18 unit per kilogram per hour IV continuous infusion. So I see some orders have been placed that my patient is to be on a heparin drip for his diagnosis of PE. And so the first thing I'm going to do is just check and make sure that a baseline PTT has been drawn, because you can't start a heparin drip without knowing a baseline PTT. And I can see from my patient, Mr. Donald Scab, his medical record that a PTT has been acquired. So I know that his baseline PTT is 38, which is well below the range where it's appropriate to give this heparin drip. So I know that I can start this heparin based on the protocol. So first I'm going to calculate the dose. Mr. Scab is 175 pounds, so I divide by 2.2 to get 79.5 kilograms. Then I'm going to determine the bolus dose, I would use 80 units times 79.5 kilograms, which is 6,360 units, and then going to divide by the dose that I have on hand, 5,000 units per ml. So I end up with a result of 1.27 milliliter IV push injection. Then, since I'm already calculating, I'll do the drip as well, 18 units per kilogram per hour IV continuous. 18 units times 79.5 kilograms is 1,430 units per hour. My concentration of heparin, I have 25,000 units in a 500 ml bag, so my concentration is 50 units per ml. And so then, using the formula, I get a rate of 28.6 mLs per hour for IV infusion continuous. Now that the dose is calculated, I'm going to go to the med room. I do hand hygiene, I put on gloves, and I'm going to drop the bolus dose. I'll use a 3 ml syringe and a blunt needle. I will inject at least an ml of air into the syringe and then drop my 1.27 mLs. I will use the scoop method to recap the needle, so not using my free hand. I will scoop up the cap and then click it on, dispose of the needle and the sharps, and immediately recap to prevent any infection. Then I will right away apply a high alert label. I've written out on my label that the drug is heparin, what the date and time is, the dose, and the patient's initials, so that if anything were to happen, I know exactly what this medication is and who it's for. Now I'm going to ask another nurse to please come in. My friend Serena, a nurse, is going to come into the room, and she's going to verify and make sure that my calculations are correct and make sure that the dose that I've drawn up is correct. And so she does the calculations on her own independently, and then I compare them to mine. She also looks at the syringe independently without hearing what I think I've drawn up. That way, she doesn't just look at it and say, looks good. So once I've verified and I know that we've gotten the same result, I've dual signed off this medication. Now I'm going to pull the heparin bag from the Pyxis. And the same with the vial of heparin, I always use the 6 rights to make sure it's the right medication and I'm drawing up the accurate dose and it's the right time to give this medication. So I will pull the heparin bag, spike it and prime it, turn the cassette upside down until the bubble fills, flip it back over, and let the line fill completely with no air bubbles. I'm also going to put a high alert label on this medication because when it's hanging in the room and someone else comes onto their shift, they need to know what the medication is and when it was hung. Heparin in the bag is only good for about 24 hours, so I just want everyone to know the date and time that this medication was hung and what exactly it is. So now it's time to go see the patient. I'm going to perform hand hygiene on my way into the room, put on my gloves, introduce myself. Hi, my name's Alexa. I'm a student nurse and I'm here to give you some medications today. I'm going to ID the patient. Sir, can you please tell me what your name and your date of birth is? His name is Mr. Donald Scab, and I know from his medical record that his birth date is 9/16/1945. So I can compare that to the label on his wrist, to his wristband, and also to the MAR. Now that I've ID'd the patient, I will also kind of just survey and make sure everything in this scenario is safe, that the bed is locked, it's low to the ground, the bed rails are up, and I don't see any other safety concerns in the room. It would also be a good opportunity for me to provide some patient education, to ask him if he knows why he's getting the medication and what the medication is for. So now I'm going to open the MAR, I'm going to verify that I have the right medication, I'm going to verify my protocol, and now that that's all good, I think I'm going to hang the heparin bag. So I hang the bag and I insert the little cassette into the place where it locks in, and it's all primed and ready. And so I would have had in the medication room made sure that it was green capped because again, I don't want any possibility for infection. I'm going to program the pump. I'm going to run the heparin primary because it's going to just be continuous bags being replaced. The rate is going to be 28.6 milliliters per hour as I calculated. For volume to be infused, I'm going to choose maybe something like 470, 480, because I don't want to run the bag dry. I want the IV pump to alarm so that someone can get in there on the off chance that I'm not back there in time for when the infusion would be ending to hang a new bag. So, and then if I could also have another nurse come in and just look at that IV pump and make sure that I've programmed it correctly. I've already had my my medication math signed off by the nurse who also checked the bolus. She checked the drip for me as well. So now that my dual sign-off has been completed, before I give any medications to the patient, I want to assess his IV site. So I assess the site for any signs of phlebitis or that the IV has moved or isn't working correctly anymore. Look for redness, swelling, hardness, a palpable cord, a red line along the venous path. I will flush the IV, ask if he's feeling any pain. I'll see if there's any pressure to the flushing. And once I've decided that the IV is patent, I'm going to scrub the hub for 15 seconds, and now I'm going to give the bolus dose. Heparin should be bolused over a minute at least, is the safe amount of time to bolus it. And I should have mentioned before, I did not dilute this heparin because 1.27 mLs I felt I would be able to draw up accurately. And also the drug guide that was listed in the lab states that a heparin bolus should not be diluted. And so now I'm going to give the bolus dose over 1 minute. And once I've given the dose, I would again flush the IV. Now I want to connect, without putting his IV down so that it gets contaminated, I want to connect the tubing for the drip to his IV. Once I've done that, I can hit start on the pump and the drip should be running. So again, this is a good opportunity for me to provide some patient education. I'm going to be monitoring for signs of bleeding, which is a major complication of heparin infusion. Signs of bleeding could be hematuria, bloody stools, bleeding gums, bleeding nose, easy bruising, but I also want to make sure that if the patient notices any of these signs or feels any symptoms that he wasn't feeling before, that he knows to report them to me. So once I've done the education, I also will remember that I need to check a PTT every 6 hours until we get the heparin level to what is considered therapeutic for this patient. Once we've had 2 therapeutic PTTs, then we could reduce the Q6 checking. Other things that we might want to take consideration of would be platelet count and INR. One possible consequence of a heparin infusion is heparin-induced thrombocytopenia, which is why we would be checking his platelets as well. And then again, in consideration of the patient's safety, I would just want to make sure that he doesn't have any risk for falls, especially that he's on this heparin, because now he has a higher risk for bleeding. And so I never want any patient to fall, but I would want to make sure that he knew where his call button was, that if he needed anything, he could ring out and receive assistance. And now that I've assessed the safety, I would make sure the patient didn't have any other needs before I left the room, and I would be prepared to come back and check on him frequently and to replace the heparin bag as needed.